even though this is not my data, it's extremely important that the data that he has and his experience should be known to our attendees, given the wide variety of cases and the number of cases that they have seen across the entire spectrum. So I think we don't need to introduce this infection. It has become ubiquitous in almost every oculoplasty clinic, with very high and increasing mortality rates, upwards of 50%, even when the brain is not involved. And post the pandemic, even pre-pandemic, 70% of the global burden of mucormycosis was from India alone. And post the pandemic, we've seen excess of 12,000 cases. So this is data from a teaching hospital, which is the Regional Institute of Ophthalmology, Banaras Hindu University. Their first case of post-COVID mucormycosis was seen on 30th April. To date, they have 176 patients who have been admitted, and of which total number of patients discharged were 12, and there have been 42 deaths. In terms of mucormycosis, the split is overwhelmingly majority of cases of 170 out of 176 were of the orbit, with 5 cases of respiratory mucormycosis and 1 of GI mucormycosis. The demographic profile showed that most of the patients were above the age of 40, and the mean age being 52, the range being 30 to 85 years. The heartening thing is that no children were reported, which is good. A majority of the patients were male, and most of them were from the urban setup. Now, this is a large tertiary referral care center that drains almost southern UP and northern Bihar. So a lot of patients were from the urban setup. As you can see, most of them were from the urban districts and the neighboring states. Systemic comorbidities, 96% of the patients were diabetic. A lot of them were, almost 50% were uncontrolled diabetics, and 10% almost were diabetic ketoacidosis. Less than 4%, 4 out of 176 patients were not diabetic at the time of presentation. You can see that the mean HbA1c was in double digits in more than 55% of the patients. This is mean HbA1c at the time of admission, with less than 5% of the patients having non-diabetic HbA1c levels, which means that poor glycemic control was almost universal across the panel at presentation. Other comorbidities included hypertension, renal disease, cardiovascular disease, and cerebrovascular disease, in addition to COPD. But as you can see, hypertension and renal disease were the most common in this. What about the COVID-related parameters? What was their correlation with the severity of COVID with the mucormycosis? 65% of them had a history of being diagnosed with RT-PCR. The others, 16% had antibody positive, which means that they probably had an asymptomatic disease. And 23% were not tested for COVID either through RT-PCR or through antibodies. Of those who were asymptomatic, 30% had home care and 14% were hospitalized. What is the duration between onset of COVID symptoms and the onset of mucormycosis symptoms? Reliable data was available for 108 out of 176 patients, and in most cases it was more than 2 weeks, which is what most of the data that is now coming corroborates with. Very few patients, 5 patients had almost coexistent disease with less than 5 days between their COVID symptoms and mucormycosis symptoms. Of vaccination status, only 1 patient was vaccinated for both vaccinations, both doses. 80% of the patients had no vaccinations taken, and 17% had a single dose taken. In terms of past history of steroid administration, 65% had a history of being given steroids during the course of their COVID treatment, and 35% did not. Inhalational oxygen, again, majority of the patients had no supplemental oxygen given during the course of their COVID. It is interesting to note that a large proportion of patients were not given oxygen, but still received steroid during their care, when steroid is actually indicated only in severe COVID, where supplemental oxygen and non-invasive or even invasive oxygen is indicated. So there is a mismatch and possibly lack of uniformity in the treatment protocol for COVID. Clinical radiological features, most of the patients had orbitofacial swellings, ptosis and proptosis as we would expect. Loss of vision was seen in more than 1/3 of the patients, and the classical sign of black fungus, as it is called now, was seen in less than 10% of the patients. The orbital involvement was seen in 26% of the patients with unilateral involvement and 9% having bilateral involvement. And in terms of the area involved, you can see that the spread was medial, inferior, superior, and apical disease, and 21 cases or 22% having diffuse orbital involvement. Cavernous CNS involvement was seen in 43% of the patients. In terms of treatment, IV amphotericin B was given to 50, the data available was for 58 patients, only amphotericin B. 35 patients received both amphotericin B as well as posaconazole, and 29 patients received only oral posaconazole. PNS debridement with alone was done in 79 cases. PNS debridement with exenteration in 43 cases, including a staggering 6 cases who required bilateral orbital exenteration. Extensive orofacial surgery, including maxillectomy, palatal resection, and neurosurgical intervention was needed in many cases. And as is the case, the course of the disease, revision surgery involving debridement was needed in 58 patients. Overall total outcome as of now we need to understand that mucormycosis disease is, and treatment is a long-term phenomenon. Patients once started on treatment need to be treated for 4 to 6 weeks at the bare minimum. So this is a point prevalence at this point, and this is a cross-sectional outcome that we are seeing. Patients alive with regression were 32, with progression was 36, and with static disease was 25, and they had 29 deaths in their cohort. In terms of ocular outcome, eye salvage was possible in 49 patients, and the eye exenteration, orbital exenteration was needed in almost half at 43 patients. So what is a pathophysiology? This is something that we're all reading, that how SARS-CoV, the virus itself, causes damage to the pancreas and induces diabetes. The local mucosal damage in the nose reduces the phagocytic effect and the inability of the ciliated epithelium to control the mucormycosis, therefore allowing the mucormycosis to become more invasive at the nose. The invasiveness in the nose and the lack of phagocytic activity because of the diabetes makes these patients extremely vulnerable. The diagnosis is typically clinical, radiological, and lab-based. The symptoms, I'm sure all of us are comfortable with in knowing it. So these are, it begins with eye ache, redness, congestion, blurring of vision, double vision, drooping of the eyelid, protrusion, and loss of vision. Also, this is not a stepwise disease. We may have patients who have loss of vision, but may still have retained some motility and eyelid movement as well. Non-ocular symptoms, because it's primarily a sinonasal disease, it begins with nasal blockage, headache, which reflects the sinus involvement, nose pain in the nose, the side of the cheeks, blackish discharge, and blackish discoloration, as you can see in the photograph below. Difficulty in chewing and loss of sensation, paresthesia, hypoesthesias around the cheek as well. Ocular signs atypically can include 6-nerve palsy, isolated 6-nerve palsy, proptosis, diminution of vision as well. So investigations that you typically do are the COVID test, your glycemic status, inflammatory markers, imaging with MRI with contrast is the standard. However, if in many cases, patients are not suitable for MRIs, they still test for COVID, positive for COVID at the time of diagnosis. So in those cases, CT can be done. A diagnostic nasal endoscopy with a biopsy at that time is important. A swab alone is not sufficient, and deep biopsy is essential. Relevant other specialty consultations and a consent for surgery. Radiological diagnosis, typically you see opacification of the sinuses and fluid level. Bony destruction can be appreciated on CT scan. On MRI, you have the typical black turbinate sign where the necrotic part appears contiguous with the non-enhancing foci. Diffuse orbital involvement in extraocular muscles as well as the intracorneal space shows loss of contrast enhancement, which shows that the orbit is involved. Globe tenting, where the posterior globe angle is increased, is another sign of increased intracorneal pressure and intraorbital pressure. Diagnosis, I think we'll have other speakers speaking on the microbiological diagnosis, which is typically through KOH and calcofluor stain. So how do you stage disease? This is one proposed staging by Dr. Maurya, where he's described it into as mild and limited orbital disease and moderate or severe based on clinical signs, which include retropulsion, ocular motility, vision, and orbital imaging, which suggests 1 or 2 quadrant of disease. Moderate or severe disease is firm with frozen globe, vision loss, and extensive radiological involvement and ophthalmoplegia. So management, early surgical debridement with systemic amphotericin B and control of the underlying diabetic or any other immunosuppressive risk factor is the mainstay. Early surgical intervention through paranasal debridement is always associated with improved outcomes. Hospitalization and multisystemic workup is needed. I don't think we need to go through the drugs that are being used. I'll quickly reach the summary. That as we know, blood sugar level control is extremely important. Liposomal amphotericin B is the first line of therapy. Conventional amphotericin B can be used when not available. It is equally efficacious, although it has more drug interactions and toxicity. Posaconazole and isavuconazole are step-down options. Avoid antifungal prophylaxis post-COVID. And exenteration is life-saving, and only but we need to know only loss of vision is not an indication for exenteration.